كلية الطب بنها، وإن شاء الله دكتورة رشا صلاح هتبتدي معانا أول محاضرة. اتفضلي يا دكتور رشا.
شكرا. السلام عليكم جميعا. طبعا يشرفني وجودي معاكم في المؤتمر بتاع اسم الأشعة قسم جامعة بنها. دي أول مشاركة ليا في المؤتمر وده شرف ليا. النهارده هنتكلم على نيو ايرا في الراديولوجي، هي البات ام ار اي in oncology، وهنتكلم عليها case based approach. This is my acknowledgement. We are going to have an introduction about PET MRI, and we will talk about the technique, and we will present some of our real cases. MRI has many applications all over the body organs, including the neuroimaging, head and neck, lung, breast, liver, pancreas, colorectal cancers, uterus, and prostate. It has a very broad-based applications in almost every body part in our body. But because of this variety, we will focus only on the abdominal organs for demonstration of its applications. PET MRI includes state-of-the-art MRI, where we perform a dedicated MRI study for the target organ, and also it have an state-of-the-art PET component, which is very valuable in nodal and distant metastatic evaluation. So it combines the highest available imaging tools for local and distant evaluation of malignant lesions. What is the PET imaging? How we can perform it? We inject the patient by the radioactive material as the CT, exactly PET CT, and then the patient wait in the waiting room for about 60 minutes, and then the patient came into the MRI scanner to start the examination. Why we prefer PET MRI compared to PET CT? Because of their nearly approximate agreement between PET MRI and PET CT, PET MRI is preferable in some particular case scenarios, especially because it is lacking ionizing radiation, so it is very helpful in imaging the pediatric age group, especially in oncology in pediatric patients, so to minimize the exposure of ionizing radiation in the PET CT. Also, PET MRI is superior compared to CT for local staging in some organs. For example, the breast, the prostate, the pancreas, and the colorectal evaluation is betterly evaluated by MRI compared to CT. Also, MRI has a higher sensitivity in depicting small lymph nodes, and there is a theory why this occurs, because PET MRI has a longer acquisition time compared to the PET CT, so this allows the tracer to accumulate in smaller lymph nodes compared to the CT, and so we can detect even smaller lymph nodes by PET MRI compared to the PET CT due to the longer acquisition time. Also, MRI is superior compared to CT in evaluation of marrow lesions, where CT can be completely negative in this early marrow involvement without affection of the cortex, which can appear as sclerotic or lytic lesions. So marrow involvement is nicely demonstrated by MRI component of the PET MRI. The preparation for the patients to perform PET MRI is the same as PET CT. The patient should be fasting for 2 to 6 hours before the exam. He should have rest and the lack of any vigorous activities prior the exam. And also kidney function tests is important, because we will inject gadolinium IV contrast for better characterization of the lesions. And sometimes due to longer acquisition and the patient irritability and in some scenarios claustrophobia, anesthesia may be used in the PET MRI as the PET CT. The bladder should be evacuated immediately before the examination to allow the patient to be comfortable on the machine, because it has a long time, so to minimize the irritability of the patient on the MRI machine. Also, the blood sugar should be adjusted as the CT exactly to allow the uptake of the FDG. As regards the PET MRI protocol, It includes the evaluation of the whole body, including the lungs, the lymph nodes, the bone, and the rest of the whole body as the CT. But additionally, we perform a local multiparametric MRI for the target organ to evaluate this local disease. This is an example of one of our patients. This is the fused PET MRI for the spine, and this is the T1 MRI sagittal images for the spine. And this is the lung evaluation. Let's start with the question that most of you are asking. Why PET MRI can evaluate lung? And because we know all that CT is superior compared to MRI in evaluation of pulmonary nodules. So MRI will have this point as a weak point in evaluation of metastatic disease regarding the pulmonary metastasis. But fortunately, we will see how we can solve this issue. Let's see this example from one of our patients performing CT, PET-CT. This is the CT images showing bilateral pulmonary nodules, and this is the fused PET-CT image with avid uptake at these pulmonary nodules. But when we perform the conventional MRI, just a T2 weighted image, we can nicely demonstrate these pulmonary nodules, as we can see over here. I'm sorry, the marker is not working. Let's see. Okay. This is the pulmonary nodule nicely demonstrated on the conventional T2 weighted images. And this is the other one which is nicely demonstrated even without the use of the PET component. And this is the fused PET MRI showing the uptake at another lymph node from one of our patients. And this is the magnificent new technique which is demonstrating the lung parenchyma very nicely compared to the CT, which is known as ZTE sequence. And we can see the pulmonary nodule over here like this. Let's compare the CT with the ZTE. This is from the literature. This is a tiny pulmonary nodule on the CT, and this is the corresponding ZTE MRI, where we can see exactly the same nodule by MRI in spite of it is a very minute nodule. And this is another example of this another tiny pulmonary nodule at the right lung, and the ZTE can nicely demonstrate this pulmonary nodule as well. This is one of our patients. This is the CT image showing this sizable pulmonary nodule along the fissure, and this is the ZTE image showing the same nodule as the CT exactly. Also, we can see that we can demonstrate the lung parenchyma nearly equivalent to the CT images by this magnificent technique. And this is the fused PET MRI showing minimal uptake at this pulmonary nodule. Let's move to the breast evaluation by PET MRI. As we know that some of the breast disease masses are negative on the PET images, so we need for multiparametric MRI for evaluation of breast masses, especially lobular carcinoma, and also the dilemma of recurrence, which is difficult to demonstrate is this is a recurrence or just a post-surgical change. Let's see this patient with the history of left breast cancer, underwent a previous conservative left breast surgery, and had axillary clearance followed by radiotherapy, and now she has a pain along the operative bed scar. Let's see the MRI, where we can see this scar with this nodular appearance along the scar on the T2 weighted image. And this is the dynamic MRI with the time intensity curve showing rapid contrast uptake followed by washout. And by this MRI alone, we can say that this nodular appearance is different from the linear rest of the scar, and this is suspicious for recurrence along the scar. And when we perform the MRI perfusion, this particular this nodule along the scar appear to be hyperperfused. And this is against the scar because scars are not hyperperfused like this. When we performed the fused PET MRI image, this scar on the PET MRI show non-homogeneous FDG uptake and appear to be relatively equivocal on the PET images, but when we fuse the MRI on the PET-CT, they appear to have minimal uptake. And relying on what we can see on the MRI, we can confidently say that this is a true recurrence along the scar, and it was pathologically proven to be recurrence along the operative bed. Let's move to another example, which is HCC, and its a dilemma in evaluation by the PET imaging, because well-differentiated HCC, as we all know, is limited by PET-CT as it have no uptake on the PET images. And also for local regional treatment, this is another dilemma where PET-CT can't very helpful in evaluation of local disease. Let's see this patient with previous liver cirrhosis and underwent a previous radioembolization for hepatic focal lesion coming for assessment. This is the fused PET MRI study showing heterogeneous lesion at the left hepatic loop, where we can see that there is increased FDG uptake at the periphery of the lesion, and so this makes a dilemma on the PET image. Is this due to the extensive fibrosis induced by the radioembolization and inflammation, or this is a true residual on the at the treated site? So when we move to the MRI, this is the diffusion weighted image where we can see that the periphery of the lesion is significantly restricted diffusion compared to the center of the left lobe focal lesion, which is completely negative on the diffusion weighted image. And so when we combine both images, these are a true residual component at the treated focal lesion and not just post-radioembolization inflammation and fibrosis. And this is the map imaging showing this avid uptake at the left loop. Another focal lesion seen at the hepatic dome, which is completely negative on the PET, and also it appeared to be completely negative with no contrast uptake on the fused contrast MRI PET study. Another nodule which is seen over here that shows minimal uptake on the PET, and it can be missed by similar non-homogeneous uptake at the adjacent hepatic parenchyma, as we can see here. But here come the role of the diffusion weighted image, which confines the confirm the presence of this metabolically active nodule to be a true tumor, not a non-homogeneous uptake as we can see at the rest of the hepatic dome, and they show no restricted diffusion as we can see here. This is another example for FDG avid lesion that is seen on the MRI, and when we cross-correlate with the T2 weighted image, we can see that this is residual tumoral thrombosis at the left portal vein branch. So it can precisely evaluate the local staging and the extent of the hepatic focal lesions even after local regional treatment based on the combined MRI, not relying only on the uptake on the PET images. And this is the metastatic pulmonary, metastatic mediastinal lymph node and also metastatic pulmonary nodule. We can see that this patient has a metastatic disease not only confined to the liver. So we perform better evaluation for local disease extent and also for distant evaluation. Let's move to the pancreas. This is one of our patients, has a metastatic pancreatic mucinous cyst adenocarcinoma receiving radiotherapy and coming for evaluation. This is the fused PET MRI study showing a complex appearing lesion located at the tail of the pancreas, and we can see that it shows nearly no FDG uptake over here, because the mucinous tumors, as we all know, are negative on the PET images. So we rely only on the MRI for evaluation of the extent of the disease, not on the PET component. And on the MRI, we can nicely demonstrate the mass with its high mucinous content, and this is the coronal image showing the mass at the pancreatic tail. What about the extent of the mass? We can see that there is negative uptake at the ascites, and this is nodular appearance at the ascites, which was demonstrated on the diffusion weighted image as a restricted diffusion. And this raises the possibility that this is not just an ascites, this is peritoneal carcinomatosis with mucinous infiltrate at the peritoneum as well. And this is the perihepatic peritoneal lesions, which can be easily missed on the CT alone, or the PET component, but on the MRI we can nicely demonstrate this peritoneal deposit, which is precisely evaluated on the diffusion weighted image as a ring of restricted diffusion. And so MRI very important in these patients for true disease extension. Also for nodal disease, we can see that there is a spacing between the IVC and the aorta by this soft tissue nodule, which is easily demonstrated on the diffusion weighted image, and it is a mucin containing metastatic aortocaval lymph node, and it is completely negative on the PET. So this patient has no role for the PET imaging for its evaluation, either the local or the distant disease or the peritoneal or nodal metastasis. Unfortunately, this patient has also left the supraclav lymph node, which also contain mucinous content, and it is again completely negative on the PET, but it is nicely demonstrated on the T2 weighted image. As regards the osseous evaluation in this patient, these are multiple osseous mucin-containing deposits seen all over the body. This is at the humeral head, and these are the femur, and multiple infiltrative marrow lesions along the axial skeleton as well. Let's see the PET-CT, which was performed just prior to the MRI, and this was completely negative on the CT with no apparent lytic or sclerotic lesions noted, because these lesions were truly marrow lesions and they are completely negative on the PET, on the CT images. And of course, both studies are negative for the PET component, so MRI is more valuable in evaluation of local and distant metastatic deposits for this patient. And this is again a comparison by the whole marrow infiltration on the MRI compared to the CT, and also the the femoral metastatic lesions, which are also completely negative on the PET images. Let's move to the rectum, which is very important in evaluation in the PET MRI. And nowadays, the NCCN guidelines, which is the most powerful guidelines in oncological management of the patient, included the PET MRI for anorectal cancer prior to initial staging, and it is implemented in the guidelines nowadays. PET MRI, it is used in initial staging, restaging after concurrent chemo and radiotherapy, and also it is very useful in evaluation of recurrence. Let's see some examples as regards the initial staging. We just don't rely on the uptake by the PET component, but we will perform the dedicated MRI rectal protocol, which is a cornerstone in evaluation of rectal disease extension and the proper staging, either prior to surgery or prior to concurrent chemo and radiotherapy. Regarding the tumor stage, the involvement of the mesorectal fascia, the lymph node evaluation, and the extramural vascular invasion. Let's see this example with this patient having this huge mid and upper rectal mass, which was fortunately FDG avid, as we can see here in the fused images. But we can also nicely demonstrate the extramural vascular component located at the anterior aspect of the tumor, so we can get the precise, proper local staging for the disease, not just mentioning that there is a rectal mass with just metastatic lymph nodes and distant metastasis. And this is the involvement of the peritoneal reflection we can see over here, and so we can get the prior evaluation of this tumor, and we can call this mass as T4A tumor due to the peritoneal involvement we can see on the MRI, and which is somewhat difficult to be evaluated by the CT. Let's see the nodal metastasis. We can see that this is equivocal lymph node located at the right pelvis, and on the PET image it was FDG avid, so this was confirmed to be a metastatic lymph node, not just an equivocal lymph node. And this is another lymph node where it can approach the mesorectal fascia, denoting that this is a positive or violation circumferential resection margin for this patient. As regards the nodal staging for small lymph nodes, PET MRI, as we mentioned earlier, play an important role for evaluation of this small nodal disease. As regards the distant metastasis, we can see that MRI is very helpful in evaluation of hepatic focal lesion metastasis based on that T2 and the diffusion weighted image. In spite of that, this nodule is completely negative on the PET, but relying on the MRI component, we can confidently call that this is a metastatic disease to the liver. And this is another example with this focal lesion located over here, and it is very nicely demonstrated on the diffusion, and again completely negative on the PET. So we don't rely on the PET component alone for proper local and distant staging. We implement the MRI component in this staging process. Also, as regards the peritoneal nodules, MRI is very helpful in evaluation of peritoneal nodules, which can be missed by the CT due to the normal tracer uptake by the bowel loops. As recurrence, we can differentiate recurrence from post-surgical change, as we can see here that this is an ugly-looking post-surgical rectal lesion, and with the use of the PET MRI, we can differentiate that this is a recurrence and this is a post-treatment inflammation. Regarding the prostate, it is very important and very helpful in local staging of the prostate. Let's see this example with this infiltrative prostatic mass located at the peripheral zone and showing extra prostatic extension. And this was showing restricted diffusion on the diffusion weighted image with infiltration of the seminal vesicle, and shows hyper enhancement on the DCE. On the PET component, the seminal vesicle infiltration show PSMA uptake, and of course the prostate we perform PSMA, not FDG. And regarding the lymph node, we can see that this is equivocal pelvic lymph nodes that can be difficult in proper staging. They are true metastatic lymph nodes or just pelvic reactionary lymph nodes. And when we can see that there is this significant increased PSMA uptake, we can confidently call that this is a true metastatic lymph nodes. And this is a smaller metastatic common iliac lymph node that was proved to be having a significant uptake on the PET component, and another left para-aortic minute lymph node. Unfortunately, this patient is also having this tiny left supraclavicular lymph node as well, which is equivocal on the conventional images, but it shows uptake on the PET component, and then this was proved to be, just to finish up, this is proved to be a true metastatic lymph node, and the final stage for this patient was T3B N1 M1A. Also, in the treatment response, we can evaluate the PSMA PET MRI in biochemical recurrence, as we can see here that the operative bed is completely negative from the avid uptake at the PET component, but there is a pelvic recurrence, and we can localize precisely where is the biochemical recurrence. So to sum up, the PET MRI avoid radiation exposure, and it allows the state-of-the-art local staging for some particular organs, which can be a difficult task to be performed by the CT alone. And PET MRI has an additive role in evaluation of nodal and also the non-regional lymph nodes. Also, MRI is very helpful in evaluation of the bone marrow compared to the CT, and the MRI can help in evaluation between operative bed recurrence and operative bed fibrosis. Thank you.
شكرا دكتورة رشا على very interesting